Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. In this episode of the Interventional Glaucoma podcast, Dr. Cathy McCabe is joined by Dr. Mark Gallardo and Mr. Dan Lindfield to talk about Elios and their pearls for patient selection. Let's listen in.
Hello, everyone. Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. I'm your host, Cathy McCabe, and today we are joined by Mark Gallardo and Dan Lindfield to talk about a procedure that can be particularly beneficial for patients who are already coming in for cataract surgery. And it can be used at the same time and during cataract surgery, which I think is a great benefit for our patients with more than one disease process, cataracts and glaucoma. So thank you both for joining me today.
Pleasure, Cathy.
Happy to be here.
So great to see you guys, or hear you guys, I should say. And so let me introduce you guys. So we have Mark Gallardo, and he practices in El Paso, Texas. And I know you've been involved in a lot of different MIGS, microinvasive glaucoma surgery, just like I have. And I'm really excited to hear your experience because you have been a champion of this space. You have so much experience. And I know that you're going to be able to give us some insights into how all of these different treatments, and in particular, Elios, fits into where you see us in our future treatment paradigm. So I'm excited for that. And we also have Dr. Dan Lindfield. Dan, it's so great to be here with you. I know you're across the great expanse of the Atlantic from where I am today, but you also have such expertise in this area, and you have experience with Elios too, just in your own practice. And it's going to be great to hear your insights into what's happening with you in that regard. So, I do want to remind our listeners that Elios is not currently approved for use in the United States, where it is now limited to investigational use. And, all of the speakers today, myself, Mark, and Dan, have experience with Elios, either as part of a U.S. clinical study or outside the U.S. So let's talk a little bit about what the subject is. And Elios is a MIGS device that we can use intraocularly. It is an excimer laser on a small probe that we can place inside the eye and visualize the angle, structures, the trabecular meshwork. And while we're doing that, we can apply the end of the probe to the trabecular meshwork and deliver excimer laser energy. And the really exciting thing is that it produces a very precise fenestration through the trabecular meshwork. And we can provide 10 of these 200 micron fenestrations that are evenly spaced throughout the trabecular meshwork. And typically that will be nasally, since most of us sit temporally during cataract surgery, and really for surgery in general, because it gives us a little bit better access. I've had an opportunity to use this. I know both of you have as well. And what we find is that really provides us with great control, great predictability. In fact, we have a lot of data also to support that. In fact, there is a study, an 8-year follow-up study that was published and has about 160 eyes that showed a really significant reduction of intraocular pressure, 29 to 43%, with about 82% of the patients having reduction in their medications at 1 year. So that's pretty exciting stuff. We're going to dig into that a little bit greater as we go through our discussion. So that's kind of to set you up as to what we're talking about, but I want to involve our guests here. So I know that there is a real movement towards making sure that we are holistically taking care of our patients at the time of cataract surgery when they have more than one disease process. And so for me, that's when patients have glaucoma and cataracts. And so tell me, what are some of your thoughts when you have patients who come in with cataracts and also have a diagnosis of glaucoma when you're about to take them to surgery? What are you really thinking in those patients? Let's start with you, Mark, and then we'll move on to Dan.
So I think that they're coupled. When I view a patient that has cataract and glaucoma, and they have a visually significant cataract, they're two disease processes that I always treat at the same time. And a lot of times we think of glaucoma as being a disease of the optic nerve, but the reality is there's a significant amount of disease and change to the conventional outflow system in a glaucoma patient that we don't see in somebody that doesn't have glaucoma. And so while we're doing cataract surgery, it's an optimal time to modify that diseased outflow system to enhance filtration and try to not only reduce intraocular pressure but medication burden. And that's something very big for me because it really improves patients' quality of life.
I love that. I like the quality of life aspect of it because we certainly think of that with our patients, right? That's kind of the holistic part of my question. And as a primarily refractive cataract surgeon, I'm thinking about what we can do to make things better. And quality of life is a huge part of why we want to offer MIGS, right?
Yeah.
What do you think, Dan?
Yeah, I couldn't agree more, really. I think we've moved away of judging purely on pressure metrics, and we're now quality of life, disease burden, eye drop burden, just how this glaucoma disease affects patients' lives on a day-to-day basis. We see our patients every 6 months, but they're dealing with drops every single day. So I think cataract surgery and MIGS is an opportunity that we should really seize. And I think if we don't even mention it or don't consider it, it's an opportunity missed. So most of my patients, hopefully all of them, are offered a combined procedure. I think there's so much to be gained from that. It's so synergistic that we really should be doing that for all our patients. A lot of the risks are already being taken. So the risk of infection and hemorrhage and visual recovery and having to use drops and the steroid response, they're already moot, really. They're already being taken with a cataract. So there's very little reason to not, I think.
I think this has been such a big discussion since MIGS first, the whole concept of minimally invasive glaucoma surgery first was introduced, and it's been quite some time now. And I think when we look at the survey data and we see how many cataract surgeons are not utilizing MIGS procedures, it's a little shocking for those of us who are passionate about it, that it really is maybe only about half of patients who are eligible or would benefit from it are receiving a combined treatment. And what are your thoughts about that? What can we do to move that number, or what's happening that stops our colleagues from offering these procedures?
I'm really surprised by that number too, because in my community, all the practices in town have been trained in one form of MIGS or another, and so patients are afforded that opportunity. But I don't know if it's a lack of, I hate to say a lack of training because they're all very well trained, but I don't know if it comes down to being a lack of interest or a lack of belief. Because as you know, for a very long time, there was a lot of our colleagues who didn't believe that microvascular glaucoma surgery was effective, and I think in large part because everything that was a part of the mixed space was being compared to trabeculectomy, and we now know that not every patient needs a trabeculectomy, and I always use the analogy that not every patient needs coronary artery bypass surgery. Most can get along just fine with cardiac catheterization. Now that we've had our paradigm shifts where we are trying to improve patients' quality of life, I do think it's important to try to adopt some form of mixed procedure so that these patients can be treated to minimize their medication burden. I once said that for a decade and a half, I was treating a chart because I was looking at a patient's pressure, patient's visual field, and their OCT, but I wasn't actually really asking the patient how they were doing. We're prescribing these medications, we see hyperemia, we see a little bit of ocular surface disease, but we don't really dive into how they're doing. And I think now there's a larger focus on that. And when you really start to focus on how patients are feeling, we realize that they don't like their drops. And so if we can do anything that we can do to minimize that medication burden, I think it's our duty. And I think that with time, with the younger generations coming through residency, they're all aware of MIGS and they all want to do MIGS. I just hope that we get to that place where 99% of patients that are MIGS qualified can actually have a MIGS procedure.
Yeah, I love that. I love that perspective too. I think the problem is that MIGS is squished between two different theories. One, it's too light compared to trabeculectomies, and then the efficacy isn't as great. Or there's the other attitude that says cataract surgery alone is going to bring your pressure down. So we'll just do that because that's enough. And I think it gets lost in the middle. And the fact is that cataract surgery alone, although it can decrease IOP, it's not lasting the way that, when we do a treatment with MIGS is. And then trabeculectomy is, I love the analogy of not everybody needs to, have CT surgery. Maybe they need a stent or something else that gets them through, and they'll avoid ever needing more invasive, more complicated, more risky surgery. And that's kind of exactly what we're trying to do with MIGS. So Dan, is anything you think that we can do to help move that needle even further?
Yeah, I think we're all on that road, aren't we? We're all guilty as scientists of comparing MIGS with trabeculectomy in the beginning. We were all guilty of always combining with phaco, and that elephant in the room of the phaco effect was always there and never accounted for. And we weren't using the right disease metrics to judge our outcomes. It's now quality of life, visual field loss, patient preference, patient choice. So I think we're already down that road, and those arguments, I haven't heard them for years now. I think we've gone past those. We're also shifting the surgical journey to much earlier in the disease process. So it's a different mentality to the filtering surgery. And the devices are evolving. I think we can all argue that the first generation of MIGs compared to where we are now, we are either bigger, more elegant, implant-free, more numerous, safer, and arguably more effective than we ever have been. And I think that's just bringing this MIGs wave to the forefront, really.
Yeah, that's great. So let's dive into your experience so far with this particular opportunity, which is Elios. So tell me what was exciting for you about using excimer laser this way, and then also how long have you been using it, and how many patients have you treated? And let's start with Mark, because I know you're involved in some of the studies there.
Yeah, so I got involved in a clinical trial a little over 2 years ago, and there's an excitement to it because with the excimer laser, we are creating full thickness channels within the proximal system without creating adjacent tissue damage. We all know the way excimer lasers work, and so the adjacent tissue isn't going to be charred, it's not going to be fried, it's not going to be melted. We all have had experience with lasers from their inception, but it's different than what we've used in the past. With the argon laser, it was a laser that truly damaged the natural outflow system. When you look at scanning electron microscopy, you can see where it melted portions of the trabecular meshwork and didn't make it more effective. I think I have a theory that just the damage that created released cytokines and allowed other portions of the outflow system to work better. But with the Elios excimer laser, we are treating the trabecular meshwork without creating adjacent damage, but we're also creating full thickness channels so that we can allow for aqueous to egress into Schlemm's canal much easier. Being part of the clinical trial, we were one of the high volume enrollers, so we treated about 60 patients, many of which are either out of their 2-year window of the clinical trial or getting close to it. And because of these full thickness channels, we were able to see that the patients have done quite well in terms of their safety and efficacy.
That's great. And Dan, I know you've had the opportunity to continue to offer this to your patients outside of a clinical trial as part of your practice. And so what kind of the things are exciting to you, and how many have you done and for how long?
Yeah, thanks, Cathy. So I've had the device for about 9 months now. We were the first delivered in the UK, not the first to use. But I've done 39 patients, I think, from memory. I'm really enjoying its precision and the 10 channels. I think that's what sets it apart from other devices. I like the idea of treating the angle widely, but with leaving some normal tissue to just be physiological and to maintain homeostasis in the canal. But I like the idea of having 10 attempts to get there. I think we'll all agree, however good a surgeon you think you are, you're not going to hit every time. I think I'll be first to say that most of us can be confident we're getting close, if not on the money every time, but it's nice to know you've got 10 shots to be exactly where you want to be. And I'd argue you probably only need 3 or 4 to be effective. But I'm really liking the smooth post-op journey these patients get. Their recovery is almost exactly the same as a cataract procedure. So my sort of threshold to offer it just comes right down. It's a similar journey to phaco alone, which is why I love it so much.
So now we have this tool. We're very excited. We have great data to support our desire to use it for patients. But when a patient comes into your office and they have cataracts and glaucoma, like what are some of the things you're looking at to decide that they need treatment, number one? And then, what specifically helps you to decide that Elios is the correct procedure for those patients? But what do you think, Dan, when the patient comes in?
Yeah, interesting to hear you say, like, what are you making what factors are you thinking to add this to the patient's procedure? But for me, it's almost the other way around. I need to have something why I'm not going to offer it, really. So long as the patient has glaucoma, so we can define that as disc damage on ACT with a corresponding visual field defect, or clinical disc appearance. As long as they've got actual glaucoma, I'd be happy to add MIGS to anyone's cataract procedure. The difficulty I have is when do you offer these patients? So the cataract patients who've got cataract, I think it's an absolute no-brainer to add a MIGS device to them. It's the other way around when they're a glaucoma patient with a bit of cataract. When do you take the plunge to bring that combined phaco MIGS to their life? How do you feel, Mark? When do you make that decision?
I've just always felt that if I have a patient that has cataract and they're going into cataract surgery, if they're on a medication, they're going to get a MIGS procedure, or if their pressure's not at target, they're going to get a MIGS procedure. Being a tertiary glaucoma referral center, of course, I have patients that have had trabeculectomies and their pressure's 8 on no medications, and so those are the ones that I don't really feel need an additional procedure. I just do their cataract surgery. But if they're on a medication or they're not at target, I automatically couple the two procedures, because, as you know, it doesn't really increase the risk or recovery of cataract surgery alone, and it doesn't really matter which MIGS procedure we're doing. They're just so safe and so effective that I just automatically add.
You really have to adopt this interventional mindset with glaucoma. You know, drops are really not the best solution. They're completely within the control of the patient. And we have very little impact other than prescribing them and advising the patient. But on the efficacy of the treatment, it is 100% reliant on the patient actually doing what you've asked them or suggested that they do. Whereas if we do an intervention, we are in control of that. And we are able to say, look, we did something that's going to be helpful for the patient. So I think a little bit of it is exactly what you said, Dan. It's when a patient comes in and they have two disease processes. When a patient comes in, for instance, for, let's say, a refractive procedure, and they have astigmatism and either myopia or hyperopia, I don't say, well, let me treat the myopia or hyperopia first, and then I'll think about the astigmatism. It's just a part of your entire mindset as you approach the patient, that there has to be a reason you're not going to address it, for you not to offer that. And I think we really need to sort of help others within our field to embrace that mindset of glaucoma is something we should be intervening. And if at some point they need drops, that's sort of the last resort. It should be that we're trying to do something where we know for sure the patient's getting an effect. So I love how you guys phrased that thought process as you go forward with your patients, because that's really what we want. Is we want to be able to do what we can to improve the quality of life and the medical experience of the patient and their disease process control.
I love what you just said, Cathy, because it really brings to light, as opposed to focusing on treating two diseases, I think we should focus on treating a patient. And if we're treating a patient, we're doing the best thing for them at that time. And just like you said, if you're going into cataract surgery and they have astigmatism, you're not gonna treat one facet, or you're not gonna just keep the refractive error the same way. You're gonna do what's best for that patient's vision. And if we're going into surgery with a patient that has comorbidities where they have cataract and glaucoma, we're treating the patient for the patient's best outcome. And so I loved what you just said.
It becomes harder when patients are referred to different specialties, different specialists for their cataract and their glaucoma. That's where it gets a difficult situation. But I'd argue that the glaucoma is the sort of top dog, and the cataract is a lower player, and that we should be really, really pushing for combined phaco MIGS for these patients, rather than just do the cataract and see what we've got afterwards. And you can always add a MIG, is always what I hear, or you can do that later. But I really think the opportunity is there at the first time.
So when we're treating with Elios and we're deciding that that's the proper treatment for the patient, what are you looking for? What are your goals for the patient as far as the outcomes go?
I think it's just like other MIGS procedures. These are patients that would feel comfortable with intraocular pressures in the low to mid-teens. Obviously, if it's a patient that needs a pressure in the single digits, it's none of the angle-based procedures are what we wanted to drive for. And so this is in the category of patients that would benefit from treatment in mild to moderate disease state, in my opinion.
I think the disease state you mentioned, Mark, is quite key as well. We've heard Carl Sheridan earlier in this series talk about how early on it's a TM disease, and later glaucoma becomes sort of deeper. The damage to the drainage systems just gets deeper and deeper and deeper into the angle and beyond into episcleral venous pressure, etc. So I think earlier in the disease, these TM based devices, procedures, are going to be more effective. The later down the line, the more knock-on collateral damage there is, and the less that the effect we're going to have by making some channels becomes. So it again pushes this mindset of just let's do this early on.
So when we talk about Elios specifically, is there anything anatomical about the patient, or maybe with comorbidities that it gives you pause in offering this particular technology?
I think they just have to have an open angle. You obviously want them to be devoid of diseases like neovascular glaucoma, simply because we are removing tissue, and if there's any form of rubiotic vessels in the angle, that will make it bleed. But it's really indicated for patients with open angle glaucoma, and I think that, like other mixed procedures, it fits very well into that space.
Yeah, I think visibility of angular structures works, but I'd argue you judge that once the lens is removed. That's my point of assessing angle structures, rather than with a phakic lens that can be affecting your angle. But the PAS scares me. Anything inflammatory, anything that I think is going to be clogged up, any pore or device stent we put in that's going to get clogged with either inflammatory material, pseudoexfoliation material, or iris to the ostia, it puts me off.
Very good. So when you're talking to your patients about this, you're getting ready for surgery, now you want to introduce it to them. Do you have some specific, words that work better, something that patients respond to better, or what kind of questions do they normally ask you?
Yeah, I think we've hit the nail on the head already. So, yeah, Mark, I've heard you use the word char. No, you haven't said nuke yet, but we've talked about sort of we mentioned these words that we kind of hand in hand with laser. They're quite kind of destructive, big kaboom style words, and it's okay to talk about that as surgeons, but patients, that just puts them straight off. So most patients you mention the word laser to think about Austin Powers or James Bond, depending on which generation they're from. But the first thing is to debunk that laser myth. It's easier now. SLT is so forefront and mainstream for most of us, but we need to just think about how we picture this to our patients. It's a precision small channel, tiny channel, 200 approximately microns, a very precise channel between the front of the eye into the natural drains. It's clearing out the blockage, and it gives us 10 opportunities to get through and help to reduce their pressure. And it does so elegantly, precisely, and without any real change in their post-op recovery.
I also focus on the size of the ostia. When I do talk to patients, and I mention the size, they don't understand 200 microns, and so I tell them that we're going to create a channel that's a width of 4 human hairs, and they say, "Oh, wow, that's small." Okay, and I said we're working in an area that is very small. We require microscopes to see this, but they're microscopic channels that allow for fluid to drain a little bit easier into your natural outflow system. And when I mention that, and they get a picture of just the area that we're treating, it makes them a little bit, it puts them more at ease, if you will.
Yeah, I love that. Any particular questions that they ask you?
They have asked if what we've seen in the past, and as part of the clinical trial, of course, when we started, us as surgeons in the US didn't have a lot of experience, but the great thing is it's not a new laser. It's been around for over a decade. And because of that, we do have a lot of long-term safety and efficacy. And I do let patients know that it's something that we've evaluated in Europe many, many years ago. It was just ahead of its time because a decade ago, we were comparing everything to trabeculectomy. And if it wasn't as good, it was difficult to get to market. And so I do also focus on the data that we have outside the US.
Yeah.
Most patients ask, will it close up? Is it permanent? And it's just lovely to have images, 3-4 years later, showing the same perfect conduits that we see on Gonia a week after surgery. They're still there, 5 years later. It's quite refreshing.
So I think like the size, the precision, the longevity of the data, how robust the data is, all of these things are very, and the fact that, it's a gentle laser, all of these things are really reassuring to patients, it sounds like. So that's great. Thank you guys for sharing that. It's been great talking with both of you about this journey with Elios and how we decide on proper patient selection and then how we talk with the patients. Are there any final thoughts that you have about that part of the journey that you want to share with our listeners, Dan?
I just think it's nice to let our patients know that these devices are out there, not just for surgeons who use them, but for surgeons who refer to us and for surgeons who don't routinely offer MIGS. I think we need to get the word out that we now have devices that we can rely upon and that patients find effective. And we've got some data to support their effectiveness. So I think it's more of a kind of public health message that we should be getting this out to a wider audience.
Yeah, I just think for us, it's just a matter of waiting for it to become approved here in the US. And once it does, it's just going to be a matter of time before we were able to educate our colleagues on the safety and efficacy of this technology.
Yeah, I'm excited as well, and I can't wait to have it in my hands for my patients. And I think it's important what you said too, that, if you don't offer MIGS, you do need to educate your patients that it is available, and then find somebody that you can collaborate with so that patients have access to treatments that would be beneficial. So thank you guys so much for joining me. And I know we're going to have further discussions as we dig into exactly how we do this and then how do we care for our patients postoperatively.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by MLAs GmbH, and the Fido laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.